Good morning. Hello. Hi. Қайырлы таң. Ассалаумағалейкум. Shalom. Konnichiwa. Ni hao. Bonjour. My name is Mynzhylky Berdikhojayev. This is National Hospital of the Medical Center of the Presidential Affairs Administration of the Republic of Kazakhstan. A presidential hospital in Almaty city, Central Asian country, Kazakhstan. And today is 14th January 2026. We are starting our day, and now 9:24 in Almaty. The case number 1, patient, 59 years old lady with a giant partially ossified calcified meningioma on left sphenoid wing and petroclival region on both sides, on right and left. Vertebral-basilar system looks okay. The right side is not so much vascularized. There is a small tumor in the cavernous sinus on the right side. I think there is no need to treat this right side, and patients were consulted in National Neurosurgical Center, and our colleagues recommended to observe the right side, and the left side was previously operated in a different hospital. Meningioma was resected. Meningotelomatosis. It's a type 1, a grade 1 meningioma. But you can see it's a huge hypervascular structure. The outside of the brain, I think it's not the aim of the treatment. We can focus on intracranial part and mostly on petroclival region. There is a meningohypophyseal artery connecting with the Bernasconi-Casinari tentorial branch of the ICA, and also there is a branches coming from the external circulation, external carotid artery. Those branches going transosseal and going to the meningioma region. This is selective injection. There are some branches meningeal from ophthalmic artery. It's not the possible catheterization branches. This branch, meningohypophyseal, might be approached, and the tentorial branch is not so clear. 3D жасадың ба? Жасап жасашы. Мына мысыға дұрыс шығар, өйткені наружный керек жоқ. I'm asking Abzal to perform the angiography 3D to clarify the ostium of tentorial branch. Yes, the ICA is stenotic. I think the option number 2 in this case might be the bypass, EC-IC bypass, and occlusion of the ICA here with the injection of liquid embolics here. It's also a possible option. We have done several cases like this. This is a meningeal artery coming from above. This branch might be coming inside the tumor. Also, we can catheterize the external circulation and can go inside the tumor and may connect the extracranial with intracranial. We can place the balloon here and inject the embolic material. Yes, the ascending pharyngeal is taking some part of the tumor. There is another branch coming from here. All those branches may connect in between. The plan in this case, just embolization without a resection in this session. It's a more than 2 centimeter portion in the posterior fossa, compressing the brainstem. I think this branch also accessible. It might be this, but there is a risk of occlusion of ophthalmic artery, as this branch is coming from somewhere. Maybe this anastomosing here and coming here and approaching here. Okay. I asked Afzal to perform the angiography and then we can decide finally. Yes, when we're dealing with the postoperative meningiomas, it's need to see the contralateral side to make a decision. Okay. This is the territory. There is a stenosis, and this is a meningohypophyseal artery. It's accessible. We can use balloon for navigation, and then we can navigate inside septor mini or something like this. Let's see the MPR. Yes. Today we took the patient under general anesthesia because of the IC territory and challenging navigation to the artery. It looks like tentorial artery also accessible here. We can access it from this part and we can go to the tumor territory and also the meningohypophyseal artery. This territory is more responsible for the tumor circulation. That's why for me it's a candidate number 1 for catheterization. Yes, it's not an easy to control the flow of the liquid embolic. You can see the tumor on the behind. Okay, let's see the extracranial circulation. Yes, we can see the meningohypophyseal artery also not so short, and it should anastomosing with this ophthalmic artery. Yes, it's quite challenging. It's need to be very cautious with the ophthalmic artery. And now I asked Abzal to do angiography from the external carotid artery, and we can see the territory. Yes. There is some branches. The meningeal artery is stopping inside the tumor. It's possible to use this meningeal branch, this one. There is a meningeal branch. Yes, it's feeding the more ostial part, and this was resected. This part of the tumor is was resected. That part is more calcified, and this part is soft, and it's bulging to the posterior fossa. I think maybe no need to do angiography from the external carotid, but it could be more clear to see the territory. Yes, and also there is no color identification. Yes, this is accessible, I think. It's going to the soft part. Абзал, қажеті жоқ. Внутреннего кривер? Внутреннего кресал. Yes, we will do it everything from the internal carotid artery. I'm not sure we need to work with the detachable catheters. Yes, and the video support, Evgeny Grishayev, video on Case-1 company. Anesthesiology team, Nazira Musabikna with anesthesiology nurse. Yes, it's a team. And operating nurse is Madina. And now I will ask Madina to give me не вересалс. Just okay. Тратор. Мына 167 деген headway ашып бересіңіз. Headway 167. Траксес ашасыз. Траксес. И так, эклипс, обычный эклипс ашып бересіңіз. Одна просветная. Okay. The patient is under general anesthesia. It's quite problematic catheterization through the internal carotid system. Перединсайдентная артерия форма? Обзор. Қарайсыз? Екі набор шприц ашасыз, Менекс. Менекс наборларын ашып беріңіз. Yes, we will work in combination Menex and the Squid 12. Menex 20 with the Squid 12. The Merrill company did a New Year present and sent to our hospital 16 vials of Menox. Thank you, Merrill company. Squid convalescence. Squid convalescence. И екі дайым су ашып бересіңіз. Yes, and this year I hope we can start to use Aptura. Aptura now has a registration in Kazakhstan, and Aptura is a liquid embolic from Spain, from IHT company, and we can do more cases in Kazakhstan, but only limit is the quotation and the number of patients with the AVM, but we will see. Okay. Тағы бір система қосып бересіңіз. Окей. Давлениесін бір өрлеп қоясың. Так, мынанышне. Но пока сухой. Алып тастайсың. Скрутчи, наверное. Hello. I'm Mynzhylky. Eclipse. Ага, шевелится. No, contrast good. It's a 60% contrast. Шевелится good. 3 cc of contrast and 2 cc of saline. We will try to catheterize with the Traxes. If it will be problematic, then we can switch. We can switch for GK Black, and the micro catheter we asked to give a 167 сантиметр не наш подводин, да, ходвойду. Ходвойду. Ходвойду. Так. Тағы да бір коннектор бересіңізші. Тағы бір коннектор керек. Андай керек, без хвостика. Balloon is single lumen. We don't need flashing for this. Она отжала пояс. Так, внутренняя крокодила, да? Нет. Хорошо. Так, пару секунд. My assistant is Abzal Jumabekov. Давай. And all patients from yesterday. Жалғап бересің? Шыл ба? Yeah, sure. Елочка жасайсың. It was closed, that's why it might be thrombus. 20 шприц бересіңші? It might be thrombus, that's why. No, thrombokopto. Thrombokopto. Yes, now is better. Да. Шинкош тромбошхна. It was some problem. Лақтырсың. Столдың үстіне тұрмай қашты. Окей. Ай, блин. Бәрін ағызып. Yes, now we're preparing the Eclipse balloon. Balloon will be used for the navigation. Оң жағын қарап көресіз? Передний соединительный артерий бар ма? There is no communicating artery. It's not so problematic, but it's quite important when you deal with the when you deal with the petroclival region meningioma. It's very important when you have a communicating artery. Okay, there is no ACOM and there is no PCOM. Okay, no problem. Okay, thank you, Maksat. Maksat in control room, and he's a great commenter. It's very important to have a headway duo 167. It's very important to have a second opinion and two more eyes in the operating room or control room. In the control room, when you are going to the complex lesion, it's very helpful. It's very helpful. It might be very helpful. That's why it's okay. 45 градус қоясыз? Қалай болған екен? Асыл ешнәрсе көрінбейді ғой, да? Прямо боковой дұрыс сияқты. Мынау көрінген екен, да? Да, осыны көре салайық. Но бұдан гөрі тенториальный сәл не сияқты, ыңғайлырақ сияқты. Пока прямой да тұра берсін. Дамадин. Бәрі нормально. Жүр. Yes, on the phone, you can, in the operating room, you can hear the Arabic words, which is the surah from Quran. The name of the surah is Baqarah. It's my experience and the experience of the team when we are dealing with the neurovascular pathology. It's better to have additional support from anywhere. It's very important to have a support and protection. When I studied in Russia, I have seen the icons and Bible in the operating room. In Kazakhstan, the population 70+% is Muslim people, and I'm also saying I'm a religious person. There is no strict religious point, but it's important. It could be a Christian icon, it could be Bible, it could be Torah, or other religious things. But if it helps to your work, I hope it's okay. I hope you understand me. Okay. Anatomically, we are in the internal carotid artery. Anatomically. Now, it was previously embolized. It was done by me. Нешінші жылы? in 2006, in 2014 in Astana, I think. It was in 7 City Hospital. Okay. It was 12 years ago, huh? Yes, 11 and a half, nearly 12 years ago. It's the early experience, huh? Okay. Patient was operated in Russia, in St. Petersburg. The first time, and the second time was operated in National Neurosurgical Center in Astana. And I think after this first session, we made a embolization between two resections. İkinci reseksiyon kaçın bu? Вперед, вперед. 17-20. Okay. The first session was the embolization. Stop. Вперед. Stop. Smart mask. Okay. Yes, it's very important to have pre-images. That's why we did a angiography to see the global view, and then at the end we may compare it with the post-op images. Okay, let's keep it in the MCA to be more stable with the balloon. Balloon could be here. And now, first of all, we will try to go to the tentorial artery. Yes, in 2014, it was the early experience since 2010 or 11. The first cases we have done with the Shimon Maimon. In National Neurosurgical Center, and then I started working in Almaty, and at that time I had more possibilities to do endovascular, more pathologies and more cases. In Almaty, I increased my experience in Almaty. Yes, most of the complex endovascular cases have done in my Almaty experience, because in Astana it's more conservative. It was a microsurgical team, and that's why it's so possible to do. Okay. We need the microcatheter to turn around and facing the orifice of meningohypophyseal artery. And also the time of temporary occlusion is also limited because of the absence of collaterals. Okay, now I think it's possible. Just a second. Okay, let's do it like this. It's facing the posterior part of the balloon. It's a tentorial artery. It's a tentorial artery. I think we need to take something like Case-8. I think the Traxxas is now kaput. Case-6 бересаншы? Madina, Case-8 бересаншы? Не де, полкада бар. Дайындық қойған. Окей. Case-8. Зеленый Case. Круга. Yes, when you don't need to go to the territory, usually the instrument is going to the territory. And when you want to go, you will never be there. No? Okay, let's take Case, which is Case-8 and abscess. Okay. Case-8 единственный кик спасал. Yes, this is not an easy case, that's why. Okay. Option number 1, we can do more selective injection to see the territory, to find the orifice. Okay, назад. I hope it will work. Double curve with small J shape. Okay, we're somewhere, but I think the artery is coming from a different point. I don't need to go there, I need to go here. No? Okay. Maybe we need to change the angulation, huh? Maybe. Okay, let's deflate a little bit and let's move it a little bit forward. Now it's possible to inflate. It's not. Yes, it could be one of the options. Okay, let's do the embryo. It's quite short segment, we need to go deeply. Yes, there is angulation, huh? Go deeply. Так, Traxxas piercers. Traxxas. Let's try to go with the Traxxas. Let's take this mandrel. Maybe now it will work. We need 1 more centimeter to be sure that we are deeply inside the meningioma and okay, let's see. It's still unstable. Still unstable. Sorry. There is a curve of the orifice. Now it's going up. Huh? Yes, I think now we need to pull the balloon. Okay, let's give the circulation. It's only the artery for this hemisphere, that's why. Okay. Yes. It's not deflating completely. Okay, let's wait. Okay, let's give 5,000 units of heparin. Bismuth. Okay, let's wait a little bit before the next step of navigation. I hope now we can support the should we do? It's a small branch, huh? That's I see. It's not then so stable. Okay. Let's take the... Maybe we need to take a hybrid, huh? It's too short segment, huh? It's too short. Yes, it's a good alternative to do bypass and then to navigate inside the tumor. Okay, let's deflate completely the balloon. Okay, maybe we need to navigate inside the proximal one. Okay. The tentorial branch, we'll see. Okay, it's not an easy, huh? Not an easy. Okay, let's give the circulation a little bit and then inflate. Назад. Вперед. Kaiser, 1 second. At this point, the tentorial branch is not visible. Алдындағы бір проекцияны қойып бересіңші. Мына не көрініп тұрған. Ветка көрініп тұрған проекцияны артқа қарай жүріңізші. Назад. Осылай. Смарт маска. Гибрид бересіңіз.
Гибрид. Айда апай. Гибрид ашсыншы.
Гибрид семерки. Семерки. Yes, there is a possible option is as in sandwich technique. It's possible to do sandwich. Okay. Let's give the circulation. Ophthalmic artery is taking care. It's a good. Женя, звук можно будет выключить? nice comments. We discussed the extracranial circulation with the Maksat. And now let's try to go with the hybrid. I think it's a very nice wire. It works in a situation when nobody works. Not nobody, nothing, huh? Nothing we do. When nothing works, the hybrid works quite nice. Yes, at this situation we can go to this tentorial branch. Yes, the more reasonable option is to do bypass and occlude the ICA. It's reasonable. Maybe safer option. Okay. Yes, when we don't need to go to this territory, it goes easily to this territory. Huh? When you need to go, it will never go. And it looks like the catheter is quite stiff. It looks like the catheter is quite stiff. Yes, we have option number 2. It's possible to go through the extracranial. I will leave the balloon in place. We can take this one, and now we can take the guiding catheter down. For the navigation. Maybe we will need one more microcatheter for the navigation. Okay. Smart mask. We need to go to the extracranial. It's not an easy with the hybrid. Oops. Let's do it. Access. The syringe is kaput. Yes. Yes, in the future, when the Elon Musk will produce a new generation of robotics, maybe I will take a vacation and will lie on the bed, on the sofa, somewhere in the world, but then there is another risk, huh? It's not so optimistic to be replaced with the robotics. It could be not so optimistic to be replaced with the robotics. I will place it like this. to have a little bit support. And now you can do it like this. Okay, let's try to go from intracranial to extracranial to intercranial. Okay, назад. Назад, стоп. Смак мозг. There is a branch going from lateral to medial. We'll try to go there. Not this one. It's something on this bifurcation. Yes. I'll put this one. Not this one. It's too small. Maybe this one. It might be painful, huh? А надо обезболить. Кыздар, обезбольте. Yes, this territory might be painful. It's close to the cranial nerves and the trigeminal nerve territory. Yes, it's close to the soft territory. It might be a little bit extravasation inside the tumor, no? Назад. Назад. Вперед. Just a second, I know what to do. Just a second. It's a contrast enhancement. We can inflate the balloon here. I think everything inside the tumor, huh? It should be inside the tumor. It's a little bit in wedge position, that's why contrast is not flashing. I'll take it a little bit like this. Okay. It's like this one. Okay, let's do Andrew. Extracranial. Deflate the balloon. Is it? As the upper portion of the tumor now excluded from the circulation because of the wedge position and the balloon. Назад, назад, назад. Назад. Назад, назад. Клипснешь. Вперед. Хорошо. Nice. This territory is on contrast. Артынан спираль орап осы ветканы қолданып жүреміз ғой деймін, да? Сол дұрыс болады шығар. Қазір. Экстравазация болады. Көрейікші, не КТ жасайсаш. Мадина, нені ашып бересіңші? Гамма өтетін шығар, наверное. Гамма дұрыс па екен? Абайлаңыз. Мынау Headway 17. Soft деген. Осыны ашып бересіңіз. И спираль 1,5-да 4 деген болса, бересіңіз. Okay, let's do Control CT to check. Okay. Yes, now we can compare the more intense contrasted territory. Yes, this part of the tumor now contrasted. Ну как хочешь, Макс? Yes. This is a tumor with contrast. Okay. We asked for Headway 17 to place several coils. Y connector керек. Бір Y connector бересіңіз, и оптим ашсаңыз. Су тауысқаныз. Так, мы баллон же сдули, да? I think we deflated the balloon. Yes, balloon is deflated. We'll navigate the second microcatheter to the same branch to place the coils, and then we'll wait for several minutes and then inject the liquid embolic through the hybrid Texas. The same Texas. Yes. Так, ну гибрид, да? I will place the hybrid inside the first microcatheter just for the navigation with the second one. Yes, I think the sandwich technique with placing the flow diverter stand with the microcatheter below after the bypass, I think it's one of the possible options. Let's keep it here. As the branch might rupture because of the because of the pressure inside the system. It was looked like extravasation, but all contrast remain inside the tumor. It's contrasting territory of tumor. Now we can use the wire for the navigation in the same territory. Let's zoom it and check it. I hope it's the same territory, no? So get some other branch. Some other branch. Yes, it's the same branch. Some kind of packet. It looks like it's a wedge position, yeah? Okay. It's quite small. Okay. Let's leave it here, and now we can leave it. Okay. Also. Okay. Kolay versin. Spiral versin. Bitirir. Поверхностно-височный. Мақсат Геевич, қарайсаш, поверхностно-височный тірі ме екен? Мадина, мынаны отделять салшы. Оптимум. Поверхностно достаточно хорошо. Емасно. Поверхностно-височный караогерида? Да. Кірмеген. Көрер. Назад. Назад. Вперед. Стоп. Назад. Вперед. Мынау тангиография дұрыс еді ғой, баллон раздутый. There is no superficial temporal artery. I think this patient is candidate for high flow bypass. Huh? Yes, the high flow will be better. We need to control the territory. That's why I enlarged the zoom. Any inflation of the balloon in the carotid artery may cause the suction effect. That's why I will try not to inflate the balloon. If we'll inflate the balloon, we will close the circulation and all collateral flow will try to go from outside to inside. And it may suck the liquid embolic. Huh? Okay. There is a risk, huh? There is a risk. Var mı екен? Вперед. Yes. Скорее всего, ненің ішінде тоқтайтын шығар. Рубецтің ішінде тоқтайтын шығар. Okay, we will check later. Ophthalmic artery, it's look like this. The tip of the wire is orienting to the ophthalmic. Now the flow is going from intracranial circulation to the ophthalmic. If we will occlude the ICA, then the blood will try to feed the ophthalmic artery and the intracranial. It might be a little bit risky. Okay, let's take a liquid embolic. Наркоз поглубже. Сквит пересол. Я его не. Сложно менекс спинарлостромс. Все отлично. Данька. I will take this microcatheter back. Okay, let's do the angio from here. Maybe there is another branches. Nice cut. I've fractured the syringe. Дем соберешь, а? Фентанил нені сұрайсыз жасайсың? Иә. Больно болады өйткені. It would be very painful. Масло видишь, каменам досватся, какие люди тут. Yes, and the next plan is to resect the posterior part of the meningioma. We will try to do it endovascularly. If it will be cutted and necrotic, then the posterior portion of the tumor can shrink, and it would be not necessary to go inside. Huh? Okay, now we'll start to inject. You should be very careful. Huh? Abzal, you need to keep your eyes on the intracranial part. Okay. It's refluxing. And we put the coils, but it's not working. It's refluxing. Okay. Okay, let's wait. The small part of the tumor now occluded. Might be the scepter mini could be the option, but usually there is a resistance inside the tumor. Rodmo? Еще раз. Yes, I see. I see there is a reflex. Yes, this territory is feeding the cranial nerves, and all the time is the percentage of the risk of damage. Huh? Percentage of the risk of damage. Especially not inflating the balloon. Yes, the aim of the embolization from this branch to connect this territory with the territory of tentorial and the meningeal hypophyseal branch. But okay, let's see. One more. Yes, maybe the obturer could be the nice option, huh? In such tiny vessels. Also, there is a experience of our colleagues from US, especially the team of Adnan Siddiqui, they using Avastin to cut the circulation of the tumor vascular bed. Yes, Avastin may work. The future of all these tumors is medication. If our medical colleagues will find, or artificial intelligence will find a new drug, and then it will be the end of any kind of surgery and radiotherapy. Just put the genetic medication and it will stop. Huh? It's look like fantastic, but it's possible future. It's a possible future. Rodmo? The flying cars, the robots was on the fantastic books and movies, and nowadays it's a part of the real life. There are robots delivering the food in big cities, and there is a robots working on manufactories. It's a part of real life today. And also the artificial intelligence like Siri, ChatGPT and other tools now became a part of real life. Okay, there is a tumor on lateral, and we couldn't penetrate more on AP. Okay, there is a reflux. It's a headway duo, and from my experience, the detachment of the headway duo is quite better. Yes, the upper middle part of the tumor from the extracranial circulation now cut it. But the aim is to connect with the internal carotid territory. Okay, let's see what's happening in internal carotid territory. It's still there. It was a experience from the team of Pedro Lilik. They placed flow diverter stents in the ICA in cavernous portion to occlude the meningohypophyseal and the tentorial branches, and it worked, and we did it once, and on follow-up the branch is occluded, but we did it for the CC fistula case fed only by tentorial artery, and on follow-up the fistula was occluded. It might be the option, but the stenosis in cavernous segment, I think it caused by the tumor. It's creating the narrowing, and I'm not sure the flow diverter will work or not. But it might be the option number something, and also it's possible to place the microcatheter in the at the orifice of meningohypophyseal artery, place the flow diverter stent and inflate the balloon inside. Create a sandwich technique. When we will have a way to go for a liquid embolic, I hope it would be occluded, and then if it's needed, it's possible to place the second flow diverter inside to fix the part of liquid embolic inside the flow diverter. Okay, it's very expensive. Maybe the radiation is cheaper. Roadmap. Yes, I'm trying to push the liquid embolic with this branch distally. We were there with the wire, and now I hope the liquid will go to those direction. Let's see. It's refluxing. It's refluxing. Okay. We have time. We can wait, and it should go. At one moment it should go. Okay, let's wait. There are Shimon Maimon's technique. Maybe we will go with the dimethyl sulfoxide to mix the liquid embolic distally. But after a couple of pushes, we need to create more stable reflux, and then we can inject a little bit DMSO. We are waiting for the patient with brain AVM, but he will arrive at 1 p.m. and he will reach the hospital nearly at 2. At 3, the documentation could be ready, but then at 5 I need to go to the airport. 5:30. Today I'm leaving to the Astana because I'm living in Astana and working in Almaty. And tomorrow evening I need to be in Uzbekistan, in Tashkent. I have several patients in Uzbekistan, and then on Friday evening I should be in Shymkent. And Saturday noon we will have several cases, but unfortunately Evgeny planning to go to vacation for Samui, which is in Thailand. He will leave us for 10 days, and we could not live stream at that time. I will do short videos, maybe it will be very informative. Okay. The specific of today's embolization, we took Headway Duo 167. It's not our regular practice. In regular practice, I prefer 156, which is more. The tip is a little bit bigger and compatible with all 14 wires and the coils, and it's possible to place little baby stand. We need to change the flashing system. Ана қоңырды ішін босатып қоя салыңыз. Ауыстырып қоя саласыз ба қоңырды? Мадина? Иә. Иә, суны ауыстыра салыңыз. Мен қазір мынаны ауыстырып жіберейін. Yes, the flashing is very important. At this case we asked for a little bit heparin, 5,000 units, but usually with the nice flashing there is no need to use any kind of heparin. Екен араластыра сал. Мынаны алсам. Все, мынаны алсам. Ана сырты жүрсін. Иголкасын мынаны кигізе салмын. Ладно. Ничего. We'll take a DMSO. It's Maimon's technique. The most of the colleagues are familiar with this technique. I have seen the modification in Essen in 2012 for René, Professor René Chapeau is using it actively after injecting a couple of cc of liquid embolic. It was there a bit before. It was there before Squid 12. He usually took 1 cc of dimethyl sulfoxide and injected inside the microcatheter, and then the next portion of liquid embolic went very fast and very smoothly. Maybe nowadays he's using the same in venous approach. It's very nice technique. Okay, let's wait a little bit. We injected a little bit DMSO, and now the squid is refluxing. We need to push the liquid embolic distally. It should be connected to territory. As you can see, the tip of the liquid embolic now at the territory of internal carotid system. Так, назад. Чуть-чуть назад. Вперед. Вперед. Yes, unfortunately, at the first session, we occluded the meningeal artery. Yes. It was very early experience, and nowadays we know how to deal with this pathology. Little bit more knowledge in this pathology, and in early 2014 we just occluded the branch without nice penetration of the tumor bed. Everything is changing and our practice is changing. Maybe in next several years a new liquid embolics, new material will allow us to do more with these patients and with these tumors. Okay, there is a reflux. We should wait a little bit more. The DMSO is going through the squid, and maybe at one point we can go distally. Yes, we shouldn't move from the first point. It was quite nice. We could inject distally, yeah? Then it might be we caused a little bit spasm in the branch, and now it's not going distally. Yes. There are many things. We need a medication which could paralyze the musculature of the artery. When you go to the branch, then injecting a little bit medication and it's paralyzing and enlarging. Huh? Then we may cause the balloon of the vessel and rupture. Okay. It's a biology. It's not just a silicone tube. It's spasming, it's thrombosing, it's occluding. Yes, it's not just simple silicone. Okay, I could not inject forcefully. There is a still reflux. Yes, it's going back. It's mostly going back. It's just pushing the distal phalange. That's the pillow of the finger. It looks like something is coming to the distal part. Yes, it looks like something is coming. Yes, it's coming. Okay, we could push it. I'll change for the squid 12 to more visibility. It's just millimeter, less than millimeter pushing, huh? Just it's going somewhere. It's not look like rupture. It's going up and it's going medial. Medial and back. We may connect with the tumor tissue. We should be very careful at this point. It might start the tumor. Oh, there is a branch. Which branch is it? Karışır? No, artery. Artery. Venom. Тоже. No. It looks like venous portion, no? I think there is a branch. Yes, a little bit occluded. This part. Yes, all this part is avascular. Yes, the ophthalmic artery quite high. Okay. Roadmap. Yes, it could be the occlusion of the small part of the tumor vein, and then we can go from the venous part to the different territory, like in AVM. It's continuing to go to the vein. I think it's the artery. Collateral circulation. Oh, let's wait a little bit. The aim was to push distally to the coil mass, but it's going everywhere, but not going forward. Okay. Yes. The territory was partially occluded, huh? Назад. Вперед. Назад. Yes, I don't want to go for all those branches. It's not so comfortable to deal with this territory. One branch is enough. Let's see. At this point, the liquid embolic should go distally, yeah? But it will say it could go, but it shouldn't. Yes. It's extravasating now. I think it's the vein, huh? It's very okay. It's not going distally. Distal territory was occluded. There is a new microcatheter from a Japanese company, Defrictor Nano. Maybe in this case it's possible to use the Defrictor. I have no experience with Defrictor, but maybe one day we will try to use it. Так, родно. Okay, let's push couple more. Closer. I think it's stuck. Yes, it looks like the microcatheter is stuck now. It's the first time when the headway door is stuck. It's not moving. Yes, it's easily detached without any problem. The tip is here. With the sonic, when you have a more proximal reflux than the third marker, it's nearly impossible to detach. Huh? But headway door is behaving different. Okay, let's see. There is no aim to occlude all. We can stage the treatment with no problem, as the brain is clear. Вперед. Okay, let's see the superficial temporal artery. Вперед, вперед, вперед, вперед, вперед. There is something, huh? It's not a superficial temporal, it's a retroauricular artery. It's feeding the territory of superficial temporal. Yes. Okay, we have option number one. We may stop now. At this hospitalization, it's possible to place bypass, or we can split in at the second hospitalization with the high flow bypass. With the same session, it's possible to resect the posterior part as much as possible, or it's possible to do bypass, then we will occlude the posterior part and see if it will be occluded. Then we can wait the surgery will need it or not. And the second, yes, there is another option. It's possible to go through the foramen ovale and puncture the tumor.
Yes.
but
So
then
we
we
send-
can create the pane.
Also, we can send to
Gamma knife.
surgery team and
They said they will not touch this part. It's better to do microsurgery. Okay, should we try more or is it enough for today?
I think it's enough.
Okay. Maybe. Okay. The tentorial branch looked like possible to catheterize. Maybe we will go now to the tentorial branch. I will try Chikai Black with the headway duo. Headway duo 156 мен Chikai Black бересіңізші, Мадина? Okay, let's try to do it. Maybe it will work. All these wires are inside. The Chikai Black has a very good abilities with navigation. Let's see, would it be possible to penetrate the tentorial branch with the Chikai Black? After this case, we have a basilar tip bifurcation aneurysm. Oh, doesn't want to go. Yes, my colleagues said me it was 2-3 times problem with the Y connectors from the bolt with the silicone here. It's not keeping. Maybe like this. Okay. Let's go. Let's see if it will work. If not, then we will wait for the second session. Okay.
Contrast, magnify.
Okay. Назад. Стоп. Смотрим. Navigate. Smart mask. Okay. One more attempt to go with the different tool, such as the black. Yes. As because of the mass of the tumor, the branch stenotica. Okay. Let's navigate to the blue. Yes, now we know the ophthalmic artery is feeding the territory. That's why it's hemodynamical reserve. Huh? Вид, конечно, это сканировал корнер, по-моему, артерия начинает разлагать. Держи, Саша. Силикон. As the small tentorial branch is a little bit problem to catheterize, but this meningeal branch, I think it's possible. Okay, let's try one more time. If it's work, it's not, then we can finish. Huh? We try to do as much as possible. Yes, the other option is just puncture the tumor. It's possible when you have a hybrid operating room. I think it's only the indication to use the hybrid room in these patients. It's good to yield. Ну, как идет она, значит, шепот. There is a kind of bifurcation at the entrance. Чуть рано стала там бифуркация. Так, чекай, восьмерка навесишь. Normal. Okay, let's try to use the checker 8. But I think now we're in a very wedge position, huh? It's This looks like we're in the wedge position. I'm trying to go to the lateral branch to have another 1 centimeter of navigation. But it's a little bit complex. Тісіктің ішіне кіріп тоқтап қалып отыр. Чуть раньше шығып кетіп отыр. Там сәл ертерек шығып кетіп отыр. Окей. Чекай блэкті өрісіш? Тарта. I hope we can drop little portion of squid 12. Свежий. Let's control and let's try to do it. Balloon is inflated, roadmap, glue. Just couple of drops without refluxing. I hope it will work. I hope it will work. Ана картинканы бір көрсетіп жіберсеңші. Ең соңғысы. Супер сөйлеп. I think we included. Now we don't need to take additional risk. Let's see. Баллон көтенде қандырыс па? I'm not sure that is contrast. It's a liquid embolic. Okay. Kaçtı birisi asılmış? Kaç? Headway 21 и кэш. Все нормально? Есть особенности. Ага. Да. Что-то происходит? Мусабекна? Что-то происходит? Подскочила? Да. Потому что больно было, да. Headway 21. Headway 21 veriyorsan catch uzunlu gerek. 40. 40. Yeah, catch maxi. 40. И нені veriyorsanız. Headway 21. Или HPC veriyorsanız. Kaç taş petrol atmış? Headway 21 veriyorsanız. Гепарин Mynzhylky. Сейчас посмотрим. Let's see what we can do. We have two options. We can do retrieval with the catch, or we can place the flow diverter stand in this segment. Let's see what we can do. This one is Chicago back. Опа, спот. The Chicago back. Traxxas новый, да? Yes, Traxxas. Okay, we will go with Traxxas. the length of the needle is a little bit short than we needed to place the taxes. Артқа қарай тарта сал. Еще. Стоп. Окей. Давление қатты снижать етпей ақ қойыңыздар. Ана тамыр бітеліп тұр пока. Мақсат бар ма? Мадина? Мақсат Гевич бар ма? Шақырасыңызшы. Yes, we have option number 1 and option number 2. Option number 1 we can Женя, микрофон можно будет выключить? Источница. Тревентин, не торопись, давай, catch. We did the consultation with the team. Unfortunately, we have no real pro. For this case, it might be ideal drug to give a little bit real pro and then place the P64. It's impossible, that's why. That's why there is option number 1 and option number 2. Option number 1, we can now inflate, balloon is inflated, we will place the catch and we'll try to take out all this squidness which were leaked behind the balloon. There is a bypass, huh? Low flow bypass. There is a low flow bypass. Yes, it's nasoorbital anastomosis. It's some part of yes, it's some part of the branches going to the skull. Вперед, вперед, вперед. Вперед, вперед, вперед, вперед, вперед. Вперед, вперед. Yes, it might be a little bit ischemia. Let's see. Мақсат келеді қазір. Okay, let's wait. With the hyperglide, we used to work with hyperglide. With hyperglide, this kind of reflux usually happens very late, but with the Eclipse double lumen, I think it's more soft balloon, that's why it's very fast refluxing, no? Usually, yes. There are significant difference between scepter eclipse and the hyperglide. Ашасал. Қазір. Just a Okay, now we are opening the Catch Maxi 6x40. It's most popular size in the department. Let's wait for the water. Let's wait for the saline, and I think it's arriving. Yeah? Yes, it's arriving. Okay, вперед. Because of the ability of Catch Maxi and the characteristics of the liquid embolics for this location, where we don't recommend to use fill behaving like a stone when it's became harder. That's why, for this reason, the better instrument is Catch. Okay, I will place it a little bit behind the. Yes, and it's a laser cut instrument, that's why we can open, and then it's possible to deflate the. Now I will take up my guiding catheter. Now we are in the cavernous segment. Okay, at this point we need to decrease the zoom, and we need to place the navigate. Қазір. Yes, you can see the movement of the embolic material. We'll a little bit retrieve the balloon with distally. Now I will start to retrieve the embolic. Okay, at this point we need to inflate again the balloon. Что выбрали, да? Okay.
Yeah.
Yes, we lost a couple of pieces. Okay, it's not a big problem. But I think there is something bigger. Okay, there is some big clot. Okay, не берешь 20 шпиц? Шпиц 20. Okay. Интересно. Чуть-чуть поторопился, надо было в этом же виде. Тартуешь? Тартуешь. Ветер. Да, в этом же виде мы его туда засунем. Okay, let's retrieve the small part. Stop. И термометр. Микрокатетер берется. Yes, maybe the idea with P64 was better, huh? Okay. Микрокатетер кельма? Кельдой, да?
Yeah.
Oh, there is a part of cloth. Oh, where's there? Okay. Oh. Живой задача. I think it's inside the system. Шпиц лысыш. 20 на ушел, да? 40 где-то. Yes. The second cloth is arrived to the... Да, массаж. 164 aşısal veriyordu. Zoom'da bir kişi yeteser. Tamam. Okay. Okay, there is no problem. It was a small something at the orifice of ophthalmic. Nerede vırdığına var mı? Minus koyasın.
Yeah, var.
Yes. Yes, the piece of liquid embolic came out. Does it? Stop. Okay, let's do one more time for the ophthalmic. And yes, the small squid will not cause the problem. Глазная артерия начинает рвать. Глазинчика не все снова отходит. Хорошо, что не будем шахтно. Okay. Now everything is stable. Kazan?
Okay.
Everything is stable. Okay. Right. Вперед. It's look like the parietal branch, but there is a cortical collaterals, and I don't think we should go there. Korkoyu collateral kepturdu. Retinalini kas ko'ramiz. I will bring my guiding down. Yes. The price, huh? Так, минус хватишь? Вперед. Окей. Вперед. Just a second. Start. Okay, let's see. There is no more tumor. Okay, it's first positive point. I'm not sure it's a price for this part of tumor. Okay, let's see. Little bit squid might be here, but there is a collaterals from the external circulation. Let's see. Yes, there are.
Yes.
The retinal artery is coming here. That's why it should be not problem. Okay, let's see something before. This was the before. Yeah? Yes. Yes, retinal artery is coming somewhere here. Ah, it's here. It's quite distal. I think with the vision it shouldn't be any problem because now it's coming here. Okay, let's do with less zoom. Rodno topsism. Rodno topsism. I hope that the patient is lucky, not lucky, lucky. Yes, with the P64 HPC, it could be also the problem. The delayed occlusion might happen. That's why. Yes, the eye is in place, the retina is in place. There should be no problem with the vision. Good. Вперед. Камни стоял басном баланс уже. Это предыдущий liquid embolic. Вперед. Назад. There is no delay in venous phase. It's a good point. And there are very nice cortical collaterals from the ACA territory. Yes, it's close to the motor cortex, but there is a branches coming. Yes, and ophthalmic artery is filling retrogradely, fully retrogradely filling. Okay, we will put the patient on the heparin for 24 hours and let's do control CT. I hope my colleagues will agree. There is no need to go to the M3, M4 segment. It might cause the bleeding. Кажется, мы победили. Посмотрим сейчас. Yeah, dear colleagues, now this is a contrast inside the tumor, which is not the question right now. We have small tantalum pieces, but it's okay. Okay. Let's see in sagittal. It's a potential complication. It's not so good, but it might happen. The small pieces of squid usually not cause the big problem in parietal lobe, but it might cause a problem in frontal lobe. Okay, let's see. Just a second, let's see the tumor. Everything is in contrast.
Там же чистый фьюз, да? Да, да. Сейчас не смотрела.
Okay, this is a tumor. Okay, okay, let's see.
12:00.
Just a second, let's analyze the last angiography. That was the last one. Okay, this is the early arterial. There is no ophthalmic artery, but it's coming from the extracranial. We have seen the nice circulation from the ophthalmic, the intracranial part, and now we can see the distal embolics, some pieces. Okay, let's see. But the most important piece is here, this one. Okay, this was the craniophix, and this one. It's most important, but the territory is coming by the collaterals. That's why I hope it would be no neurological deficit. It's a quite a motor cortex. Yes, it's a coronary suture, and from this point 3 centimeter. Yes, it might be, but it might be also the sensor cortex. Let's see. After extubation, I will inform at the comments. Thank you. Thank you. See you in 30 minutes. Next case is basilar aneurysm.